Hello, everybody. Over the next few minutes, we will discuss the role of next-generation imaging for advanced prostate cancer. Here are my disclosures. So we'll start off by reviewing the central role that bone scans and CT scans play in prostate cancer care, while we acknowledge the limitations of bone scans and CT scans. We should become familiar with the potential uses of next-generation imaging technologies, which include multiparametric whole body MRI and PET CT scans with various tracers in different advanced prostate cancer states. We will then discuss the biases that we need to take into account that come in as we use more sensitive imaging. And finally, with that, we'll be able to acknowledge that we require a higher quality of evidence on the management and the outcomes impacts of the use of next-generation imaging technologies if these technologies are going to be more widely accepted, and more importantly, we get paid for these services. So the first thing to realize is that advancing prostate cancer is categorized using a prognostic model. And in this prognostic model are the patient characteristics, the radiographic extent of the disease, i.e. bone scans and CT scans, and of course the testosterone levels. And highlighted in pink are the advanced states. Now, the important thing for you to recognize is that the presence or absence of metastatic disease and its volume is determined by bone scans and CT scans. So you can see that next-generation imaging is therefore detecting microscopic metastatic disease or microprogressive disease, and this is not incorporated into this model. Now, the presence of metastatic disease, its volume and distribution, form risk groups, and it's on the basis of these risk groups that treatment decisions are made, because these risk groups are mostly prognostic, but in some cases are predictive. So if you look at these two graphs, you can see that this is a metastatic hormone-sensitive prostate cancer. And on the left-hand side, you can see that patients with lymph nodal disease have a better survival than those patients with visceral disease, for example. And the number of sites is also prognostic, as you can see on the right. So both of these graphs are showing you that the distribution of disease is prognostic and therefore will affect therapy choices. The distribution is also predictive. So if you have metastatic hormone-sensitive prostate cancer presenting with metastatic deposits, and you want to decide whether to give patients radiotherapy or not, if you have less than 3 bone deposits, then that predicts for an overall survival advantage to the administration of pelvic radiotherapy. And you can see that if you have 4 or greater, there is no advantage. So you can see how that's being predictive of a response to pelvic radiotherapy. On the bottom, you've got almost the same definition, but this time we're looking at whether patients with metastatic hormone-sensitive prostate cancer will respond or not to docetaxel chemotherapy. And you can see that whether you have low volume or you have high volume, both of them respond. Not only both of them respond, you can see the hazard ratio is almost the same. Of course, patients with a higher volume disease respond less than patients with lower volume, but nevertheless, this biomarker is prognostic in both low volume and, of course, high volume disease. So with that background, we also recognize that CT scans and bone scans are not perfect, because we often have rising PSA levels and we don't see anything at all in a number of disease states. So locally advanced prostate cancer with nothing seen on a bone scan or CT scan, high-risk biochemical recurrence, for example, we don't see anything on a bone scan and a CT scan. And there's this condition called non-metastatic castration-resistant prostate cancer, where we don't see anything at all on a bone scan or CT scan. When you do PET scans in these patients, you will see something. So, for example, if you take high risk biochemical recurrence, and this is these patients here, you can see that 42% of men will have metastatic disease. And of course, the higher the PSA level, the more likely you're going to see a metastasis or local tumor recurrence. And this not only applies at a baseline, but also applies during therapy monitoring. So you will often see imaging stable metastatic disease when a patient's being treated with some type of therapy, yet tumor markers are going up or the patient is clinically progressing, and you won't see any changes on imaging. And here's an example. So here's an 86-year-old man with castration-resistant prostate cancer who is being treated with an immunotherapy and a PARP inhibitor. Now, as you look at him going left to right, you can see that we have prospectively used CT scans and called this patient stable. Now, he was clinically deteriorating, was taken off the clinical trial because of unequivocal clinical progression. And you can see that once we took him off the trial, we were able to unblind the PSA, and the PSA level has gone up. But you'll also notice that the whole body MRI, which was done before and after, clearly shows progression. So this next generation imaging technology is showing progression, which the CT scans was unable to depict. And this is not at all unusual. So if you look on the third line there, you can see that unequivocal clinical progression, in other words, the worsening of the clinical state, not seen on a bone scan and CT scans, occurs in up to 38% of patients in the castration-resistant state when they are being treated with abiraterone. But you see this happening for a number of treatments in a number of different situations. So because of these issues, there's been a great deal of interest in identifying more effective strategies to inform on the likely management of cancer patients. And modern imaging, next generation imaging, is effective because it can detect microscopic metastatic disease or microscopic progressive disease. But by being able to do so, it is in fact disruptive. But the evidence for their use in clinical practice is in fact quite limited. So what you find are papers like this, where we say next generation imaging allows the early initiation of treatment in people with occult metastatic disease not seen on bone scans and CT scans, or it enables optimal treatment changes via the earlier detection of disease progression. Now, both of these statements are making a claim that patients are better off using next generation imaging technologies. But in fact, there's been a lot of pushback from our clinical colleagues regarding statements like this. Because what they say is they would like to see next generation imaging demonstrate other benefits, such as maximizing treatment benefits, minimizing undertreatments, reducing or even preventing overtreatments, tempering costs, for example, when biases are taken into account. Now, what are these biases that they are talking about? Well, next generation imaging technology, we said, improves detection sensitivity, in other words, microscopic metastatic disease, and it improves the depiction of microprogressive disease. We also know, in fact, that it can improve bone response categorizations, which we'll talk about shortly. And this can lead to three major biases: stage migration bias, length time bias, and lead time bias. Now, from an advanced prostate cancer perspective, the two that we need to focus in on is stage migration and lead time bias. Now, on the top right, you can see the literature sensitivities of choline PET, PSMA PET, and whole body MRI against bone scans and CT scans. And you can see clearly that these techniques are more sensitive and more specific than bone scans. So what that means in practice is that the improved sensitivity results in a stage migration. So if you thought a patient had locally advanced non-metastatic disease, with a next generation imaging technology, you may well find that the patients have oligometastatic disease. And if you thought they had a few bone mets or a few lymph node mets, in fact, you would find more disease. So in other words, higher sensitivity tends to cause stage inflation. Now, you will find on conventional imaging false positive patients, which you'll say isn't metastatic. Okay, so higher specificity will cause stage deflation. So higher sensitivity and higher specificity will move different patients into different groupings, and this results in a survival time bias. And let me just explain that to you now. So let's say you have conventional imaging and you divide patients with metastatic disease and non-metastatic disease, and you can see their survival times on the right-hand side to any particular therapy. Now, you know that in conventional imaging that there will be non-metastatic patients there. You'll have some false negatives, in other words, microscopic metastatic disease, and you'll have some patients who have indolent disease, patients who are going to progress very slowly. And then on the metastatic side, you'll have patients who have truly got metastatic disease, and you'll have some false positives. Okay. Now, if you use the next generation imaging technologies, bidirectional changes take place because false negatives, these two folks here, will move here because of increased detection sensitivity, whereas this false positive patient here will move in the other direction because of higher specificity. So in other words, the next generation imaging technology will increase the prevalence of higher stage patients. Now, it turns out that both of these groups will survive better. Why is that? Well, if you look at the non-metastatic patients, you can see that this is now a purer group. So their survival improves from that to that. Whereas the metastatic disease patients also improve in their survival times. And that's because you diluted people with a lot of deposits with people with indolent disease and people with microscopic disease. And so now you can see how you have altered the balance of the groupings, and it looks like both groups are surviving better. But individually, each patient is surviving as long as they were going to, because you haven't changed their therapies. The other thing you've got to realize is that survival is apparently improved because of something called lead time bias and something called length time bias. So lead time bias is the earlier detection of microscopic metastatic disease, and length time bias is due to the over detection of indolent disease. So let's just discuss these two concepts a little bit more detail. The overestimation of survival duration due to the over detection and the over treatment of indolent disease that's going to progress very slowly leads to something called length time bias. Lead time bias is the overestimation of survival duration due to the earlier detection of microscopic disease or microprogressive disease if an earlier therapy causes no survival impacts. Now, let's just think about that for a second. So higher sensitivity means an increase in the detection of, or an earlier detection of disease. So let's say you had conventional imaging here. This is when you detect the disease, you treat it, and the patient would survive at this point. Now, use the next generation imaging technology, suddenly you're detecting at this point. Now, if you use the same treatment and the patient lives just as long, this overall survival seems to be improved, but it isn't really, because all you have done is detect a microscopic metastatic disease at an earlier time point. And you find a similar thing happens in the response assessment paradigm. So you know that conventionally we divide patients into being progressive or non-progressive categories using bone scans and CT scans. Now, next generation imaging enables you to split this apart so we can distinguish now stable disease from progressive disease to responding disease. Now, within the progression category, you can pick up microprogression and gross progression. And because you can pick up microprogression at an earlier time point, that also results in a lead time bias. So let me just illustrate. So let's say you had conventional imaging, and here's when you diagnose, and there's your first treatment. This is when you diagnose progression on conventional imaging, and then eventually the patient passes away at this point. Okay, so if you use next generation imaging and you diagnosed here using conventional imaging, but you detected progression at this point using next generation imaging, and again, if you use the same treatment and you have the same survival, then this apparent improvement by the use of next generation detecting progression earlier, in fact, this is lead time bias because overall the patient didn't live any longer. However, if you were able to intervene with a different type of treatment, say a second treatment at this point when you saw microscopic progression, such as say metastasis-directed therapy, and then when they progressed again, you use the treatment that you were going to use, then in fact you'll be able to push this out. So that's the only time that you'll be able to improve overall survival is if you could intervene on the second treatment with a appropriate therapy. And so these are biases that are very much present. And clinicians will point to a number of other things. They'll say, therapy approvals are linked to bone scans and CT scans, so I have to use bone scans and CT scans. They will say they can't get paid for bone scans and CT scans, so why do I want to use it? And as I said, it's not entirely clear whether there are truly benefits accruing for patients using these next generation technologies, particularly when we take into account all these biases. So these are real issues that we as radiologists need to get a hang of. Now, the question really is, do we need to show improvements in management? Well, as far as the regulator is concerned, they say we do not need to do this. So you can see these are two studies that were published recently that led to the FDA approving PYL-PSMA for practice in the USA. And you can see the statements in both of those patients. What they say is the impact of PYL on patient management was not prospectively evaluated. Lastly, whether the use of PYL will impact on survival and other outcomes remains to be determined. So it's interesting how the regulator looks at this whole process, because what they say is that there is no regulatory requirement to show management or outcomes changes for a diagnostic biomarker. And if these diagnostic biomarkers have prognostic or predictive value, then they say that the clinical value of these biomarkers will be increased. But if you want to show that something is prognostic and therefore helps management, then you need to do a different set of experiments to show that. Okay, so if we look at the latest Asco guidelines on the imaging of advanced prostate cancer, they say that imaging should be done. They also say that if the treatment or the prognosis is unlikely to be changed, don't use next generation imaging. Bone scans and CT scans will be fine. Okay, so what are the indications in which they recommend the use of next generation imaging? Well, if you look at high-risk locally advanced prostate cancer, they recommend the use of next generation imaging if conventional imaging is either negative or suspicious, but clinical suspicion is high, if the detection of additional disease would alter management. And here's a patient. So this patient clearly has a locally advanced prostate cancer. You can see he has a Gleason 9 cancer. It's T3A disease. And here, for example, are the bone scans showing two abnormalities. You do the CT scan. These are unconfirmed bone scan abnormalities. So this is suspicious but not diagnostic. So does he have metastases? Is this oligometastatic disease? Should he have prostate radiotherapy? Should he have metastasis-directed therapies? So these are clinical questions that would affect patient management. And then you can use next generation imaging technologies, and you can see that the right acetabular lesion is on PSMA and whole body MRI a metastatic deposit, as is the lesion in the left seventh rib. And you can also see that he's got multiple other bone deposits. And in fact, this was looked at in terms of its management impacts, and you can see how the management impacts of this next generation technology increased by the use of PSMA in this particular study. Now let's take the example of biochemical recurrence. Remember, the low-risk biochemical recurrence patients don't apparently benefit from pelvic radiotherapy, but the high-risk biochemical recurrence patients do benefit from pelvic radiotherapy. So high-risk biochemical recurrence patients with negative or equivocal conventional imaging, in whom salvage therapy is being contemplated, in these patients, you can use next-generation imaging technologies. And you can see that low-risk biochemical recurrence patients can live many, many years and still have an excellent cancer-free survival, whereas if you have high-risk biochemical recurrence, these patients will fade away over time. So these are the people that you can salvage. So salvage radiotherapy to delay progression after prostatectomy is limited to patients with a fast doubling time. In other words, high-risk prostate cancer patients. And if you look at the chance of you seeing metastatic disease in a patient with high-risk biochemical recurrence, we talked about this before, is in fact 42%. And there are management outcomes or impacts on this. So you can see how using PSMA in the setting of biochemical recurrence, and in this particular analysis, they didn't distinguish between high and low risk. You can see management changes occurred in 45% of times. And look at what happens to the use of targeted therapies. Targeted therapies increased from 31% to 64% by the use of PSMA PET-CT scans. Now, hormone-sensitive metastatic disease can either be at the time of the initial diagnosis, in other words, synchronous metastatic disease, or it can occur some time after definitive primary therapy, either radiotherapy or a prostatectomy, in which case it's called metachronous. And it can either be low volume or high volume. So what about the use of next generation imaging technologies in this condition? So the Asco guidelines say that you can use next generation imaging technologies in this state if the upgrading would make a difference in your management. So for example, if you were planning to do, say, metastasis-directed therapies, and you saw more disease and they would put you off, then you can do it. If you wanted to increase the confidence for using chemotherapy for patients who have apparently low volume disease. So let's say you have a patient who many years later presented with low volume metastatic disease, and you were suspicious that the patient might actually have higher burdens of disease, then you can use it to clarify what is going on. And let me show you an example of that. So here's a man who looks like he's got low volume, low risk metachronous prostate cancer. You can see that he presented in 2011, had external beam radiotherapy, and many years later he develops a rising PSA, has mid-back pain. But if you look at this image, looks like low volume disease, but you are suspicious that there is something going on here because he's got back pain. That doesn't necessarily explain his back pain. And in fact, when we did multiparametric whole body MRI scan, you can see that he's got high volume, high risk disease because it's got a cord compression and he's got polymetastatic disease. So you can see how we upgraded on the basis of clinical suspicion. So this is a very good indication for the use of next generation imaging. So we went from where we thought he might have low risk disease, but we were clinically suspicious, to in fact finding out that he had high risk disease, and in fact in the end he had docetaxel chemotherapy. So we escalated his treatment. Finally, for metastatic castration-resistant prostate cancer, you can use next-generation imaging technologies for therapy monitoring, particularly in those patients in whom there is a changing clinical state, but the clinical findings are discordant. And I showed you an example of this previously, where we had a patient who was getting worse clinically, but was stable morphologically. So next generation imaging technologies can be used in that instance. And the Asco guidelines state that you can use next generation imaging to assess the extent of progression if you already performed next generation imaging at the baseline. And here's an example of the use of next generation imaging to follow progression in both hormone sensitive disease and castration resistant disease. So this patient got ADT alone for metastatic hormone-sensitive prostate cancer. And you can see that as the PSA begins to rise, we perform next-generation imaging with whole-body MRI. And what you notice is that the volume of disease appears to be increasing into the retroperitoneum and, in fact, in the left groin. So at this point, it goes on to abiraterone. And again, the PSA goes down. And as the PSA begins to rise again, what we do is we start doing next generation imaging here, here, and here. And look what we see. So at this point, what we notice is that he's in fact had an excellent response to therapy within these retroperitoneal lymph nodes. But look what's happened to the groin nodes. His groin nodes have increased and he's beginning to develop bone deposits. And as you follow him over time, you can see he develops more and more bone disease. He develops metastases in the right pelvic side wall. So you can see how a next generation imaging technology is able to spatially map where progression is occurring. In this particular instance, we're saying the patient is progressing in the left groin, is progressing in the prostate, and is progressing in the bone marrow. And we couldn't have said any of those things if we had just used the PSA test. So here are my final take-home messages. Next generation imaging technologies such as PET scans and whole body MRI certainly has better detection sensitivity and specificity than bone scans and CT scans in both the detection setting as well as in response assessment, so it has multiple potential clinical applications that could transform patient care. However, management and survival impacts of these next generation imaging technologies has not yet been shown for the majority of the APC states, and we need higher quality evidence for greater clinical acceptance and for payments for our next generation imaging services. I hope you found these remarks helpful. Now let's get on with our cases.